Alright, so now we're up to the topic of fever, and then it's just the few things that are not really that new in the tick-borne infections, and a couple of miscellaneous topics, and we're done with infectious disease. We looked at this question last time, and this was a really nice question up here because it was about a topic that, well, I'm pretty sure none of you might have actually previously heard of this topic, and this question was good for two big reasons. One, because it was very well worded, so even though you may have never actually heard of the topic, you could actually figure out the answer. And second of all, because this is the kind of case scenario that will take place both in your real life practice as well as on your step 2. It definitely happens a lot more in step 1, or not a lot more in step 1, but it's definitely something you might have already experienced in step 1 if you've taken it already, where there were topics in your step that you read the question and you were like, I've never heard of this before. Now when it comes to step 2, it's a little more frequent there actually, but you obviously haven't taken it yet, so you didn't know or haven't experienced it. But on step 2, what happens is that you'll see questions that start off with topics that you know about, like this guy, previously healthy 35-year-old man, is evaluated for new onset fever. And yeah, sure, you know about fever. Or so you thought, and then you start reading the rest of the question and nothing makes sense, and then you keep going and you're just like, okay, I've actually got nothing to categorize this as, but you have to use your best judgment, right? You have to use your best analysis of things, and you have to recruit whatever medical expertise you have, your understanding of physiology and pathology, and then pick an answer choice that really locks in and makes sense to the person's case scenario. So I know we've done this question, but let's take a look at it again just to really break it down. So you read the first sentence, 35-year-old middle-aged man with new onset fevers. Usually where do we think of fever? Well, mainly infection, sometimes inflammation. But there are other things that can also cause fever too. But mainly, for the majority of people, it'll just be infection, and then a few times it'll be inflammation. He was admitted 9 days ago following a motorcycle collision that resulted in severe traumatic brain injury. Okay, it's a traumatic brain injury and multiple extremity fractures. Alright, so it's got a couple problems now. Most likely wasn't really wearing a helmet. The patient initially required mechanical ventilation and multiple interventions to lower his intracranial pressure. Okay, so that was 9 days ago. He has since stabilized and underwent fracture fixation and tracheostomy, with subsequent weaning off of mechanical ventilation, so now he doesn't need it. Yesterday, while receiving a sponge bath, he was noted to be diaphoretic, as well as hypertensive, and tachycardic. So, I want to stop here and talk about the fact of pain, right? These three things together, diaphoretic, hypertensive, and tachycardic. Hypertension can result from, again, many things. Most commonly, it's idiopathic. Other times it can be related to diet, or just, primary hypertension, where you just have hypertension because it was destined to be. One of the other things that can cause hypertension is extreme pain. People who are in pain, especially people that we commonly know are in pain, or people who are actually going through opioid withdrawal, right? When you're addicted to opioids and you don't have any more opioids, the opioid withdrawal actually makes you feel pain, even though there's really no reason for you to be in pain. It's just a opioid thing. Those people also tend to be slightly hypertensive, and if you're actually going through pain with the reason for the pain, you also can develop hypertension. So hypertension is also a thing that happens with pain, and it's worth remembering, especially for the clinical practice as well as CK. So at this point, this guy who's just getting a bath and then randomly starts getting very sweaty, hypertensive, and tachycardic could be because he just had a pain moment. But and they go on to tell you that his symptoms improved after morphine administration, which further supports the idea that he was just having a pain moment. Today, during routine repositioning and vital sign measurement, he again becomes diaphoretic. His temperature is high. Blood pressure is very high, right? 194, 110. Pulse is also very high, and he's breathing really fast. So this presentation of high fever, right, or pretty high fever, 101, point A, very high blood pressure, very fast pulse, very fast breathing. This is something we rarely ever actually see in questions or even in real life practice. It's not a common thing to see this, right? So this presentation that you're seeing, most likely, when do we actually become like this? Well, the only time I would be in this manner is if someone told me, something extrememe like panicky, like, oh, all your stocks just went to zero, you just lost all your money in the bank, or someone really, really precious to me just died. Like something really crazy would have to happen for me to become this stressed out that my blood pressure is so high and my heart rate and breathing are super high. Right? This feels like a panic attack with a fever, which again doesn't really fit panic attack. It's some next level thing. They go on to say after that the oxygen saturation is perfectly fine. So even though he's breathing so fast, his lungs are working just fine and everything's okay in that aspect. On exam, heart sounds and lung sounds are all normal. Neurologic exam shows eye opening and withdrawal of all four extremities in response to painful stimuli. So everything is actually pretty good. Right? Nothing's wrong in terms of any of these exams they're doing. What is the most likely cause of his abnormal vital signs? So then the only thing that could possibly occur, and as we said the last time we did this question, the only thing that could occur that would cause all four of these things in the vitals, right, temperature, pain, pulse, and respiratory rate to be super high, would be your sympathetic nervous system just went into overload. Why would your sympathetic nervous system go into overload? Because you had a really bad brain injury, and that's it. If you have very sympathetic activity, then that should remind you of things that we've seen before with atropine and whatnot in pharmacology. And that's all this question was about. So this is a really nice thing. And remember, if you still feel even slightly discomforted by the topic of autonomic drugs, this section of Step 1 Pharmacology, then it's one you want to continue revisiting, right? Continue revisiting, understand the difference between parasympathetic versus sympathetic, the breakdown of your nervous system, central and peripheral, and then these drugs, all their messengers. You don't need to know the messengers so much for CK, but you should know this already from Step 1, and you do need to know it for Step 1. And then really getting a good hand at the different things of anticholinesterase poisoning, where you basically stopped your acetylcholine from doing anything it was really going to, the acetylcholine was going to be destroyed. You stopped it from being destroyed. So now you have too much acetylcholine. And that's exactly what acetylcholine esterase poisoning is, right? It's anticholinesterase poisoning. So cholinesterase, the thing that was going to stop your acetylcholine, is no longer there. So you have too much acetylcholine, which is too much parasympathetic stuff. And this person actually kind of sort of looks like the guy in our question. Right? To some extent, not entirely, just to some extent. He's got the sweating, he's, but the part that doesn't match is that he has bradycardia, whereas the other guy has tachycardia. And that's because acetylcholine is parasympathetic. Our guy is going through a sympathetic thing. The parasympathetic aspect is just rest and digest, and this person here is clearly doing a lot of resting and digesting, and sweating is one of the special things. So if you recall, sweating, let me see, it should be right here on the beginning. Sweating is one of your special guys right here. The sweat glands, right? Sweat glands. It says sweat glands here with the sympathetic thing, but it actually utilizes acetylcholine and muscarinic. You see how this is the only guy, if you notice that this here is the only guy that uses acetylcholine. Everything else uses norepinephrine, epinephrine, and then the one dopamine guy, right? So when you activate a lot of parasympathetic stuff and you have your acetylcholine reaching all the way over here, you also end up sending acetylcholine over here. So even though you're doing excessive parasympathetic shit, you could end up activating sympathetic sweating, but not the other guys, not these other guys. The final messengers for these other guys are different. So the sweating is the only thing that doesn't really give away much, but everything else he's doing is clearly resting and digesting. Right? He's got the pinpoint pupils, he's got the frothing, he's got the diarrhea and the urination, vomiting, all of that. Right? He's full-blown acetylcholine mode. Then you have atropine. Atropine was the exact opposite of that, right? Atropine overdose causes all of these things, which this is our patient, right? This is definitely our patient, hot with the fever. He's got the full-blown, where's the heart rate stuff here? They don't have the heart rate stuff here. Oh, right there. See, increased heart rate, right? Increased body temperature. He probably has disorientation as well, but they're not talking about his mental orientation aspect of things. And none of the other things here really fit. Yeah, so it's just the heart rate and the increased blood pressure, right? Which right away is all sympathetic things. Now, of course, these are the only two things that match because we're talking about atropine specifically, not full-blown sympathetic activity. But if you look at full-blown sympathetic activity, then other things your sympathetic nervous system does cause is to increase your breathing and just make you look like you're running, right? You're running because sympathetic is fight or flight. So the temperature and blood pressure and pulse and respiratory rate, when they all go up together, always consider that to be a sympathetic thing, and then look in the question for why in the world could this patient possibly have excess sympathetic activity. And in this specific patient, it was because of his brain injury. You could also have brain injury that leads to excess parasympathetic activity, as we've seen earlier with the Cushing ulcer, right? With acute gastritis, where you had a really bad brain injury, and then the patient ends up getting excessive parasympathetic activity, specifically in the stomach area, and that of course releases more acid, right? So those are some interesting things that can occur that always link different topics to each other, and the question can seem very offending, very intimidating. So here they break down fever of unknown origin, right? So temperature that's above 100.9 for at least 3 weeks duration that remains undiagnosed following 3 outpatient visits or 3 days of hospitalization. So you visited or been at the hospital for quite a while, and your physician just cannot figure out why you have fever. This presents with fever, headache, myalgia, and malaise. The differential diagnosis includes the following: infectious, neoplastic, autoimmune, or miscellaneous. And then there's 10 to 15% where it could be idiopathic. Now, I've never really seen a question where someone has idiopathic fever. So this is something that I would, not worry about too much. I can't imagine why anyone would have idiopathic fever. But these other case scenarios are what you'll actually get tested on. Now, we've already seen enough infectious questions, right? TB, endocarditis, any of these, osteomyelitis, blah, blah. These things are all different case scenarios that you get questions on that people will, of course, have fever because they have infection. But the neoplastic stuff is rarer, right? This is what you could definitely get a question on and be confused about. So lymphoma, leukemia, hepatic and renal cell carcinoma, and then autoimmune, still disease, lupus, cryoglobulinemia, polyarteritis nodosa. They're just listing out all these things where these are differentials to consider. Diagnosis: confirm the presence of fever and take a detailed history, including family, social, sexual, occupational, dietary, any kind of pet or animal exposures, and travel. Obtain a CBC with differential. Check if there's inflammation by checking ESR. Check their SPEP. Remember the SPEP thing, serum protein electrophoresis, was for multiple myeloma. So this serum protein electrophoresis was supposed to show you if the patient has elevated M protein, or the M spike. The M spike, which was IgG in actual multiple myeloma, but it was other things. In the other similar differentials of multiple myeloma, it was IgM. Multiple blood cultures, sputum gram stain in culture, urinalysis in culture, basically order everything, even check for their PPD. Right, so this is going to be part of your what should you do next with the patient. These are things you'll pick, but they're pretty obvious things to pick, right? So it's not so bad. You even go ahead and do specific tests for some of these other things that they mentioned here, right? So for lupus and whatnot, you could check for this antibodies, right? You could check for viral cultures for HIV, viral serologies, antigen, everything. Check everything to really, check for each one of these boxes, basically. You're checking each one of these boxes. The CBC with differential will help you figure out lymphomas and leukemias. Obtain a chest x-ray, CT of the chest, abdomen, pelvis, every little possible thing. You're ordering it all. So this ends up being a very expensive patient, mainly because you couldn't really figure out what was happening to them. You've already gone through 3 weeks with 3 visits or 3 days in the hospital, which is already expensive in itself, and still don't know why they have fever. Treatment: stop any unnecessary medications. Patients with FUO and a completely negative workup, have a favorable prognosis. Alright, so if you found out nothing after all these tests, then at the very best, you've at least been able to cancel out that it was any of these things. So it wasn't any of these things, and you're okay with that now. You're okay, you're confident, and you just wait. Fevers end up resolving over months to years. You just wait. You don't do anything else. So that part is probably going to be the difficult aspect of the question. You can get a question about fever of unknown origin. The question might go on and tell you they ordered X, Y, and Z tests, nothing came out, and they put the patient on A, B, and C medications. What should you do next? You should just take them off all these medications because you ordered all these labs that told you nothing is wrong, and the fever will just get better. That's it. All right. So it's a very, very weird topic, right? Very weird, very uneventful topic, and there's no climax. The point of climax for all these questions is supposed to be you read the question, you're like, oh shit, what's happening? Like watching a movie, and then all of a sudden you find out who the villain is, which is getting a diagnosis, right? But there's no climax here. That doesn't happen with fever of unknown origin, and it is a topic that can throw you off. Over here on the side, they wrote, overall infections and cancer account for the majority of cases of fever of unknown origin, FUO. Autoimmune diseases account for 15%, and in the elderly, rheumatic diseases account for 1/3 of cases, right? Which can also be painful, rheumatic diseases. So pain-related fever can also be a thing. Now, let's take a look at what they put in the book as questions themselves. So question 1 here, 45-year-old woman presents to the emergency department with fever, chills, nausea, vomiting, and severe flank pain, right? So flank pain usually means something's wrong with one of the kidneys or ureters. It's unilateral stuff, right? I don't know if they said bilateral, but she definitely has severe flank pain. Could be bilateral, usually unilateral. If it is unilateral, especially when it's unilateral, it's usually a kidney stone in one ureter. She has a history of multiple UTIs and was recently hospitalized for pyelonephritis. Urinalysis reveals pyorrhea and bacteria. Ultrasound performed in the emergency department shows what appears to be a perinephric abscess. So perinephric abscess is somewhat of an abscess in the kidney. What's the next most appropriate step in her management? What do you do for this woman who has an abscess perinephric? Right, so this is a topic you probably haven't really seen much of, but you're quickly going to learn as you approach the end of CK and getting ready for residency, and you start looking at books related to working with an attending of the specific field you're looking into going into. Then the answer is almost always hospitalize the patient. If your patient has an abscess, you hospitalize them. Hospitalize the patient, and then of course, since she has infection, she has fever and whatnot, you're going to give her antibiotics. Right, so hospitalize and give antibiotics. The most obvious answer you could possibly pick for a patient presenting with fever and abscess that clearly tells you is the cause of her fever. This patient has complicated pyelonephritis and therefore needs to be initially managed as an inpatient. Can't just send her home. Antibiotic therapy can subsequently be narrowed and converted to PO as patient circumstances permit. Right, before you even start the antibiotics, if possible, you would try to actually take a culture as well of the abscess, if you can figure it out. Otherwise, you might be able to figure out what bacteria it is just from the urinalysis as well, because there were bacteria in the urine. And once you know exactly what bacteria you suspect, you could change up the antibiotics as well. But that was the obvious thing you would have to do with this patient, right? Just hospitalize her again. She's already been hospitalized many times. You hospitalize her again and deal with this perinephric abscess. You can't just send her home, because you have to monitor if the antibiotics you gave her are actually fixing her infection and helping give her the abscess. Next one here, question 2. A 17-year-old boy presents with 1 week of fever, sore throat, and progressive fatigue. Physical exam reveals palatal petechiae, large tonsils with whitish exudates, splenomegaly, and cervical and axillary lymphadenopathy. So you should already kind of sort of have an idea of what's probably wrong with him, especially given his age. The patient says that he has been too tired to attend football practices and is concerned that he may lose his spot on the starting roster. What is the most appropriate advice to be given regarding his participation in athletics? So looking right at his presentation, his age, and then the way this question is phrased, advice on his athletics. Since when do physicians have to play the role of coach? Well, the reason for this question being in this manner is that this could be, especially with his cervical and axillary lymphadenopathy, this could be Epstein-Barr virus-related infectious mononucleosis, especially at his age. The key thing to focus in on is the splenomegaly. Right? He has splenomegaly. If he keeps playing sports, he could actually break his spleen. And then remember, there's supposed to be no contact sports if you have splenomegaly, especially due to Epstein-Barr virus. He can actually lose his spleen and he could be in serious issues. So no more sports until this gets better. That's it. And then he'll be just fine and he won't lose his position in the starting roster. Right, so they tell the patient to refrain from contact sports until his physical exam normalizes. Splenomegaly secondary to infectious mononucleosis puts him at increased risk for splenic rupture. That's it. And so these were two questions where you see the patient presenting with fever, but it's a very typical presentation. It was a very typical presentation of fever. Both questions that you've probably not that surprised to see fever in. And on top of that, both had a climax of some kind of diagnosis and resulting fixing, right? Dealing with the diagnosis. Next topic, neutropenic fever. This is defined as a single oral temperature of 101 or a temperature of 38 101 or temperature of 100.4 for more than 1 hour in a neutropenic patient. So neutropenic means that you're kind of running out of neutrophils. Right? Neutrophilia is too many. Neutropenic is you're running out. So they tell you absolute neutrophil count, ANC, less than 500. Alright, so what could be causing fever and make you lose your neutrophils? That sounds pretty oncological. Common in cancer patients undergoing chemotherapy. Neutropenic nadir, 7 to 10 days after post-chemotherapy. This term nadir is going to be used a lot more when you get to your gynecology and in your obstetrics chapter with respect to the charts of heart tracings, fetal heart tracings. So definitely keep that word in mind. Here they're just telling you that about a week after starting chemotherapy, most people do become neutropenic. Most patients, cancer patients. Inflammation may be minimal or absent. Conduct a thorough physical exam but avoid a rectal exam in light of the bleeding risk if the patient is thrombocytopenic, which can be the case. So just do a basic physical exam and that's it. No need to do the rectal exam here anyway. This is probably not a patient who has some kind of rectal problem. Obtain a CBC with differential, check everything, all their other organs, if they're working or not, the kidney, bleeding inside, hemolysis, the liver, right, and then check for cultures. You're basically going to end up having another expensive patient because, once again, all case scenarios where fever is really problematic and not clear and obvious fever, you can't do much about. Chest x-ray for patients with respiratory symptoms, CT to evaluate for an abscess, and just get them started on empiric antibiotic therapy. Right? Also include Pseudomonas as one of the possibilities and give the medication like piperacillin for Pseudomonas. Vancomycin for any MRSA coverage, right? Everything. You put in everything in the antibiotic to cover everything you can until culture results come back and maybe you figure out more specifically what's wrong. Routine use of colony stimulating factors is not indicated, and this is the most important part of this little topic. Right? Usually when a patient goes into chemotherapy and then they start losing a certain colony of cells, whether it's white blood cells or whatever, you give them granulocyte colony stimulating factor, the GCSF, or you could give them GM-CSF, which is granulocyte macrophage colony stimulating factor. You give them things that will help them remake the things they're running out of, except in neutropenic fever. Right? And if the fever persists after 72 hours despite antibiotic therapy, start antifungal treatment. Maybe they don't have a bacteria, maybe it's some kind of fungal problem. Right? And your HIV test results should be coming back soon too from whatever the patient's hospitalization cause is, and maybe that'll make it more obvious for why they might have some kind of fungal infection. Right? Because fungal infection doesn't really occur unless you're pretty immunocompromised. One of the other things, let me just find it, granulocyte colony stimulating factor. Pretty sure it was mentioned. Yeah, right here, okay. So the medications you often have to give for bone marrow stimulation are these guys, right? And you can see how when a person has leukopenia, you can give them these colony stimulating factors. You can give anyone lacking platelets for whatever reason a platelet stimulator, and if you have anemia, you can give them erythropoietin. But you don't do this in fever-related stuff, right? Neutropenic fever, you don't give it. So don't pick that as an answer choice. You will have that as an answer choice. In fact, first of all, in these questions, they'll really focus on telling you that the neutrophil count is really low. Other counts might also be low. They might even have anemia. And then they'll be like, what should you do next? And you're going to be very inclined on picking one of the colony stimulating factors because it will make them replenish what they're lacking. But it doesn't really work that well. It doesn't really work that well. So very important to keep that in mind. Here is a topic of ehrlichiosis in this table, which could be one of the case scenarios that could present with neutropenic fever. Because if you look at the lab findings, leukopenia and thrombocytopenia are right there. As someone who has ehrlichiosis, which is transmitted by a tick, and we're going to get there now, you can end up seeing a patient present with some very basic vague symptoms, flu-like illness, high fever, headache, myalgia, chills, which is the topic we just finished. Ehrlichiosis can cause confusion and may have a rash, but it's pretty uncommon, right? But it could have a rash. It could have a rash that mimics Rocky Mountain spotted fever, but without the spots. It's just a weird rash, right? That's ehrlichiosis. Lab findings are going to have leukopenia and thrombocytopenia, which is what's supposed to help you figure out this is ehrlichiosis. Elevated liver and LDH. Intracytoplasmic morulae in monocytes, which, again, if you see this, then the diagnosis is done, right? But they're probably not going to tell you that in the question. PCR, of course, would also confirm the diagnosis, and then treatment is with doxycycline, right? That's it. So this is showing you how there are many things that can cause leukopenia and thrombocytopenia, especially with fever. When you have febrile things, you don't treat them the same way you treat it without the fever. When someone doesn't have fever and they're neutropenic, then you could give them colony stimulating factors. It would make sense to. But if they have a fever and they're neutropenic, you don't. You just wait, right? And then you keep checking with the antibiotic therapy, keep checking if the fever goes away. After the fever goes away, then you can look into giving them colony stimulating factors if necessary. Chances are, after the fever goes away, they'll replenish what they were lacking. They'll rebuild their neutrophil count above 500 again, and they'll be okay. Right? So ehrlichiosis is a pretty big topic now when it comes to CK. Most of us probably don't know too much about ehrlichiosis right away, and it's not one that we talk about a lot, nor is it a very high yield topic, but it's actually pretty important, very, very key and worth remembering and worth understanding. Human monocytic ehrlichiosis and ehrlichiosis in general. Ehrlichiosis is a disease transmitted by the Lone Star tick, endemic to the south, central, and southeastern United States. It causes headache, fever, chills, altered mental status, and myalgias, but rash is uncommon. So when you see all these things, right, those symptoms are actually the same symptoms you would see in someone with Rocky Spotted Fever, right, Rocky Mountain Spotted Fever. But the Rocky Mountain people would have the spotty rash, including rash in the palms and soles. That was one of the things for the Cars mnemonic. Ehrlichiosis could have a rash, possibly, but it will definitely not be on the palms and soles. That's something I want to make sure I let you guys know, right? Because although they tell you rash is uncommon, they don't say rash is impossible. And on your test, there will be a rash on the ehrlichiosis patient. You need to see if the rash is on the palms and soles too, because if it is on the palms and soles, then it falls into the Cars mnemonic with Coxsackie and rickettsia, and Rocky Mountain Spotted Fever is rickettsia. So that's how you differentiate between the two. Otherwise, rickettsia also presents with the same symptoms: fever, altered mental status, myalgia. And then they go on to tell you leukopenia, thrombocytopenia, and elevated liver enzymes are common lab findings, which also don't really occur in Rocky Mountain Spotted Fever. You don't see thrombocytopenia and leukopenia there. You definitely don't see leukopenia there. So when you start seeing these things together, you should just give the patient doxycycline and they should get better. So first thing they go into here is Lyme disease, which was a huge topic on step 1, right? Mainly with the target lesion, but then it moves on to being a bigger deal when you think about secondary and tertiary late disease, right? So tick-borne disease caused by the spirochete Borrelia burgdorferi, usually seen during the summer months and carried by the Infectious tick on white-tailed deer and white-footed mice, endemic to the northeast, northern Midwest, and Pacific coast. So let me show you guys really quickly the sketchy micro image for this. When you watch the video again later on, you can pause and check it out with more accuracy and read the story. Let me see where it is. Wait, no. Let's just do this. It should show up right here. There you go. So, as you can see in this image, you already had the deer and the mouse. They got the primary, secondary, and tertiary levels of disease. This guy in the middle his name is Borrelia, and he's the guy that's actually the protagonist. And these two are here showing you the stain you use to treat it, or to culture it, I mean, right? So this guy's name is Sir Wright, and this is Sir Giemsa, because you use Giemsa Wright stain to actually check it out. Right? And then here is the full story for this guy. Right, so there you go. Later on, you can pause and check it out and read the whole story and get the image pretty well if you need it. And here they tell you doxycycline is first line, and then they have more information here because, of course, your test won't have doxycycline as an answer choice, right? It's what happens all the time. So the other answer choice is amoxicillin. Amoxicillin, and if severe illness, CNS signs or heart block exists, even ceftriaxone. Right? Not just doxycycline. Doxycycline may be first line, which is why he's on a unicycle. But then his shield has the 3 axis for ceftriaxone. The only thing they don't have in this image is the amoxicillin, which is usually a pencil for penicillin, but they don't describe that. Right? So you need to figure out what medication you use based off of how bad things are. Right? And that's basically it for this stuff. Coming back here. Oh, actually, also worth remembering. Remember that the Infectious tick also carries other infections. Right? It's also the vector for anaplasma as well as babesia. So someone who gets Lyme disease is also at risk of those other 2 things, and it's something you have to keep in mind as a physician, because if you get a patient with Lyme disease, or that target lesion, the bullseye lesion with central clearing, then you need to also screen them and check them for the other 2 diseases they could have possibly gotten, right? And then treat them for all of it. So they go on to tell you, presents with onset of a rash with fever, malaise, fatigue, headache, myalgias, and or arthralgias. Infection usually occurs after a tick feeds for more than 18 hours. Erythema migrans begins as a small erythematous macule or papule that is found at the tick feeding site and expands slowly over days to week. The border may be macular or raised, often with central clearing, so it looks exactly like that. So basically the tick was chilling right here, right, feeding itself, and it's done feeding, and then you get this target lesion. Later on, this can become early disseminated disease, which presents with migratory polyarthropathies, pain in all your different limbs, neurologic phenomena of facial nerve palsy. Bilateral is also classic for Lyme disease, and that's the bilateral bell palsy. So you see the 2 bells in stage 2. And then lymphocytic meningitis or myocarditis, and a conduction abnormality with possible 3rd-degree heart block, which is why his shield has a heart on it, this guy. This, if you still haven't found treatment for it yet, then this can get worse, leading to arthritis and subacute encephalitis with memory loss and mood change, right? And things get really bad by that point. The migratory arthritis also gets really bad, which is why you have a moving body. And his arrow hit the head because of the confusion that you would find, encephalitis. So how do you diagnose this and how do you treat this? Early Lyme disease is diagnosed on clinical grounds alone, erythema migrans plus the fact that they went somewhere. Serologic tests are not required or recommended because as IgM becomes positive 1 to 2 weeks and IgG takes 2 to 6 weeks after onset of erythema migrans. So ordering any of these tests won't really work out. You would have to wait a very long time, and the longer you wait, the more the disease is progressing. Early disseminated or late Lyme disease presenting with consistent symptoms and exposure risk factors should be diagnosed with serology. If ELISA, IgM, and IgG are positive or equivocal, then Western blot for confirmation it can be ordered. So now we're seeing, they told you in the early part, don't order anything. You can diagnose it based on the story and if you see the target lesion. But now that you waited long enough, or maybe the patient took a long time to come, you can order these things, right? So do the serology and then confirm with Western blot. So ELISA and Western blot. Right, ELISA and Western blot. Do not use for screening or non-specific symptoms. Western blots sent without ELISA have a high false positive rate, as is the case with any of these little spirochete things. So it's not really a preferable thing, not a fun thing to worry about. They then go on to tell you that treat early disease with doxycycline or amoxicillin in kids under 8 years of age or in a pregnant patient. More advanced disease should be treated with ceftriaxone. So basically up here you would use the doxy, over here you would use ceftriaxone, and if they're allergic to doxy or have any contraindication to giving doxy, then you can use amoxicillin. Right? So that's all you really do for Lyme disease. But now what they don't mention on this same area is let me see. Yeah, they don't mention the other two guys, right? So they say consider empiric therapy for patients with the characteristic rash, arthralgias, and the fact that they went somewhere. Prevent with tick bite avoidance. So if you have a patient that comes and tells you they're about to go somewhere, then you can also tell them, oh, watch out for ticks that would go ahead and get stuck on your skin and do this. Lyme disease or prophylaxis. Lyme disease is not usually transmitted within the first 48 to 72 hours of tick attachment. Give 1 dose of doxycycline if all the following apply. Tick is Eczetus scapularis and has been attached for more than 36 hours. Prophylaxis is started before 72 hours of removal. And local rate of infection of ticks with Borrelia is more than 20%. If the criteria are not met, simply observe and treat only if the erythema migrans develops. So now this prophylactic part just got really technical on you. It just got really technical. They gave you a list of things you have to check for, and only then do you actually do something, otherwise don't do anything. So let's take a look at this question and get a better understanding. A 14-year-old boy is brought to the office by his camp counselor due to a tick bite. He arrived at summer camp in Vermont earlier today and spent the afternoon outdoors. So we're looking at this map stuff again. This is a nice map because this time you actually have the letters of the states that are involved. This is from UWorld. This guy right now, he's in Vermont, so that's up here. About an hour ago, he noticed a tick attached to his right thigh. He has no fever or pain at the site and has no chronic medical conditions. So you see, he doesn't have anything. No fever or pain. No chronic medical conditions about him, but he doesn't have He doesn't have fever or pain right now from the tick. Vital signs are fine. Physical exam shows a small brown tick attached to the right medial thigh with an area of erythema 3 millimeters in diameter. So there's a little bit of erythema where it's attached. Everything else is unremarkable. What is the best next step in his management? So they say, just remove the tick and reassure the patient. Don't do anything else. And to remove the tick, you have to make sure that this is how you do it. It's actually something they talk about a lot in step 2. You have to grab it right at the head. Grab the head and pull it out. If you don't grab the head and pull it out, let's say you grabbed it right here, grab the tail with the forceps and pull it out, you actually risk breaking the head and then leaving the head inside, which would really suck, right? Because if you leave the head inside, then you probably won't be able to get the head out anymore, and there's even a chance that the head might actually suck itself into the skin, which would just end up staying there, and infection would only get worse. Okay, so you grab it at the head and you pull it out, and it should just come out like that, and then you could send it somewhere if you need to, but otherwise you would just kill it. So really just don't do anything. Reassure the patient. Very important. Why? Well, 20% of people chose to apply petroleum jelly and prescribe doxycycline for 21 days, but that's a little excessive for a kid who doesn't really have any crazy symptoms. Eczetus scapularis deer tick is endemic to the northeastern U.S. and serves as a vector for several zoonotic infections, including Lyme disease, anaplasmosis, and babesiosis. Transmission of disease occurs when organisms pass from the tick salivary glands into the bite wound. Anaplasmosis and babesiosis are typically transmitted soon after attachment, but Lyme disease resides in the gut of the tick and requires 48 to 72 hours of feeding before salivary gland migration. The first step in tick management is removal with small forceps as close to the skin surface as possible. The body of the tick should not be squeezed or crushed because this can expel secretions into the wound and increase the risk of transmission. Oh, that's the other thing, right? If you squeeze here, you're going to squirt more of the saliva into the patient. Surrounding erythema during tick attachment is typically due to local skin irritation from the tick saliva, not infection, right? Anything bites you anywhere, you get a little bit of redness. That's exactly what his little bit of 3 millimeter redness is. Antimicrobial prophylaxis is not effective against anaplasmosis and babesiosis, but is recommended to prevent Lyme disease if specific criteria are met. And then they give you the same criteria, the specific criteria that's mentioned here. If the deer tick is attached for more than 36 hours, a prophylactic single dose of doxy is indicated within 3 days of tick removal if local infection rates are high. Local infection rates, where that basically means not only does the tick need to be attached for more than 36 hours, but the area that we're in right now must be an area where a lot of people get Lyme disease. Otherwise, you don't do it. This patient has had a tick attached for less than 36 hours and therefore does not require anything. Not even the single 1 day doxycycline. Alright. So that's really, what you're going to be looking out for. This little technicality is what you're going to get tested on, and it's going to get a little annoying. Just be very careful. Right? Tick testing is a common incorrect answer choice. It has no effect on management and is not performed in a Lyme disease workup. So don't fall for that either. Right? Don't fall for the take out the tick and check the tick. No. No one has time to check the tick. Forget that. Okay. Then they go on to the next guy, babesiosis, which also can come from the same tick. Tick-borne protozoal illness, also transmitted by I. scapularis, as well as the eye here. This is Ixodes. Ixodes scapularis, high rate of co-infection with Lyme disease. Causes flu-like symptoms, intravascular hemolysis and anemia, as well as jaundice. And you see these Maltese crosses inside the blood smear. This you treat with azithromycin and atovaquone. Very interesting that you need to use those things. So right here we just got down Lyme disease, right? We understand it. We see all the things that are relevant. We understood the treatment, doxy, amoxicillin, and then ceftriaxone if it got really bad. Now let's move on to babesiosis. What is this? Yeah, right here. So I searched the word babes because that's exactly what the image is about. Babesia makes this Maltese cross. You see this? And you see how it's discussed in the same spot as our malaria topic? Because you use the same medication, atovaquone. Right? Atovaquone right here, we just did malaria a couple days ago. Where is the atovaquone proguanil was the strong medication that you use when you don't have enough of chloroquine or mefloquine activity. And then the other strong medications were the quinidine, the artesunate with the Artist, and of course primaquine was always necessary for the hypnosoid with the Vivax and Ovale. Now coming to babesia, here you use atovaquone with azithromycin. So right here is the image for babesia. That's the story. Once again we have our same guy again. Borrelia of Burgdorferi from the Lyme disease image. He's apparently been caught by a bunch of vampire babes, right? That's what this image was about. So the babes here are for babesia. You still see the same ticks, and then you have the Queen Atova for the medication you would use, right? And the fact that she's holding a sickle and he's missing his spleen are to remind you of a couple things that can occur here, right? So this story here will tell you the relevancies of that. And other than that, asplenia increases the risk of severe disease. So what that's reminding you is if you have a patient who's sickle cell, right, or anyone who doesn't have a spleen, then the infection is more likely to occur, right? So the sickle is important because most sickle cell patients are a victim of autosplenectomy, so they don't have a spleen, right? And that's really all there is for this. It's not that intense, not that hard. In fact, in CK, they don't even have anything else they're talking about here. Right? It's just that. So if you get a patient who has Lyme disease or was bit by a Ixodes tick, it had been more than 72 hours, they got the full-blown rash, they had some polyarthralgias, you started treating them with doxy, they got better. But then at the same time, although those symptoms got better, they also had these other symptoms of anemia and whatnot. Then you start looking into the fact that they probably also got co-infection with Babesia. Now they don't really tell you much in the book about what it does, right? They just said fever and hemolytic anemia. That's it. Not much else, right? So then in your question, you'll probably have a patient with fever, hemolytic anemia, and possibly splenomegaly, and right there, you start looking into treating this as well and add atovaquone and azithromycin into their regimen. All right. So those are going to be some things to watch out for. Rocky Mountain spotted fever. So now you see the rash on the palm. Rocky Mountain spotted fever is a disease caused by the Rickettsia rickettsii and carried by the American dog tick Dermacentor variabilis. The organism invades the endothelial lining of capillaries and causes small vessel vasculitis. Presents with headache, fever, malaise, and rash. Characteristic rash is initially macular, beginning on the wrists and ankles, but becomes petechial, purpuric, and spreads centrally. Altered mental status or DIC may develop in severe cases. Clinical diagnosis should be confirmed with biopsy and indirect immunofluorescence of the skin lesion. Treatment is simply doxycycline and they'll be just fine. The condition can be rapidly fatal if left untreated. If clinical suspicion is high, then go ahead and give them doxy right away. You don't wait for the test results. Chloramphenicol can be used during the first 2 trimesters of pregnancy in uncomplicated cases, but if it is not available, doxycycline therapy should be initiated. So even if the patient is pregnant, now remember chloramphenicol. Chloramphenicol is not a medication that's great for pregnant people either. It had this thing called, I believe, if I remember correctly, gray baby syndrome. Let me see. Chloramphenicol. Not a medication we talk about that much, but pretty sure. Yeah, so here they tell you, you've seen your rickettsia guy, right? Doxycycline, caution during pregnancy, alternative is chloramphenicol. You can see how the rash is beginning. This is a guy that's coming up, right? No rashes, then rashes everywhere, but not in the center, and then it's everywhere, including the center, including the palms and soles. So it starts outside, comes inwards, right? That's something they'll describe. It's part of the Cars mnemonic of Coxsackie A, Rocky Mountain spotted fever, rickettsia stuff, and syphilis. Right? These are the only 3 guys where you see rash in the palm and soles also. Right? It's a huge thing to use for your general understanding of diagnosis. And then if we actually look at chloramphenicol in your antibiotics, so let's see where they talk about it. Yeah. So chloramphenicol, yeah, it does cause it. See, gray baby syndrome in premature infants because they lack liver UDP gluconeogenesis. Now, gray baby syndrome or the doxycycline with the yellowing of the teeth and whatnot are both problems in pregnant women, but the gray baby syndrome is more appreciable, more acceptable than the doxy issue. So if you have a pregnant woman, you give them chloramphenicol, and again, you have to give them whatever you have to give them because anything, when you weigh the risk of dying, anything is better than the fatality, right? So it's a pretty easy diagnosis with the rash aspect and very easy to deal with. Nothing insanely difficult about it. Take a look at this question. 25-year-old man comes to the office due to right hand pain and swelling. He injured the skin over his right knuckles when he punched a man in the teeth during a bar fight 3 days ago. He ignored the wound initially, but his hand became more painful and swollen yesterday. He has no medical history and takes no medications. Received the tetanus toxoid vaccination at age 18. Temperature, blood pressure, pulse looking okay. Small lacerations over the right third and fourth metacarpophalangeal joints with surrounding erythema, swelling, and tenderness. No discharge or crepitus is present. Hand radiographs reveal no foreign body or bone joint changes. Cultures are obtained. What empiric antibiotics is most appropriate for him? So all that really happened was a bar fight, right? And the hand now, after the bar fight, has become painful and swollen. And when you look at it, you're seeing lacerations. The only way you could have a bar fight and get lacerations with no weapons involved is that he must have punched the guy in the face, as they said, in the teeth, and the teeth dug into his hand. So this is considered a human bite, essentially, right? So what would you give him? Amoxicillin and clavulanic acid. Remember, the clavulanic acid was a medication that increases the effectivity of amoxicillin. It's just supposed to be given together. 30% of people chose clindamycin as well. So why? Why was this discrepancy here? This patient experienced a bite wound from a clenched fist, fight bite injury. Human bite wounds are prone to polymicrobial infection with aerobic and anaerobic oral flora. Blood and wound cultures should be sent and empiric antibiotics are required. Although large studies on empiric antibiotic selection for human bite wounds are scarce, amoxicillin clavulanic acid is often the treatment of choice due to excellent coverage of both gram-positive and gram-negative, as well as beta-lactamase producing oral anaerobic organisms. The beta-lactamase is the reason you give clavulanic acid. It stops the beta-lactamase. Surgical debridement is usually necessary, and wounds are typically left open to drain and heal by secondary intention due to high-risk infection with closure. So don't close the wound. Don't pick that answer choice. Do not pick the answer choice of closing the wound, wrapping it all up. I first saw this in a case scenario where something exactly like this did occur, where a person had a really bad fight with some kind of personal issue with someone else, and the patient was just sitting there and their wound was open. You don't wrap it all up entirely and just seal the whole thing away, because then you create an environment for the bacteria to actually prosper. You leave it open so that you can continue draining, continue applying any lotion or whatever you might need to apply on top of it, antiseptic stuff and whatnot, and just let the person heal until it's all gone. Then once they're not infected anymore and there's no chance of any more further infection, you just wrap it all up, put a little band-aid on it, and they're good to go home. Okay, so you have fight bite or human bite wounds, also critical stuff. Humans can be ticks to other humans. All right. And then that's it. Then in the next thing we'll wrap up miscellaneous infections and we'll be done. And that's the end of that. Tomorrow morning, I might be a little later than usual, so we'll figure that out. Just because I have to just drop my parents off to the airport, so I'm just gonna drop them off at the airport and then I'll be right back. So if you're not very busy, just log on and wait, and I'll be right back as soon as I can, and then we'll wrap up infectious disease tomorrow, and we'll be ready to move on to neurology as we go through March. All right. So thanks a lot for joining, guys, and take it easy, and I'll see you all tomorrow.